In this next section, we're going to talk about how to approach a patient with pain. It is important to ask several questions about patient's pain because, unlike many other disease states, there's not often an objective way to tell how much pain a patient's in. Think about it. If you have a stomach ache, I can't check a blood pressure to see that you have pain. I have to ask you questions. I have to make sure that I know exactly what's causing your stomach ache. And this is going to help us figure out what the etiology behind the pain is as well. So let's take back that stomach ache. There's many times people can present to the ED with complaints of general upper GI pain and end up having a heart attack. The questions that you ask to follow up that from I have stomach pain helps determine whether or not a patient needs further workup and what kind of workup the patient's going to get. So this is really important. Now, there are some things that we do for every single patient, of course, which is we have to ask about patient-specific characteristics such as their age, their gender, and whether or not they're pregnant, because there are certain medications we want to try to avoid in pregnancy. Then we want to ask about the patient's history, such as current and past medications, pharmacological and non-pharmacological trials, so what medications have you tried before, or what therapies you've had, allergies and medication intolerances, family history. There are certain disease states like rheumatoid arthritis and Crohn's disease that are associated with the family history of having them. So knowing whether or not the patient has this family history can help us determine therapy as well. Always asking about social history, such as tobacco use, alcohol use, and recreational drug use. You can check the prescription drug monitoring program to help make sure that the patient's not getting drugs from multiple different sources as well, as far as getting prescriptions. You can also ask about exercise therapy to try to figure out exactly what kind of non-pharmacological therapy the patient's used in the past. Always good to ask about co-occurring mental health conditions such as depression, anxiety, as it will help us decide what kind of therapy would be appropriate for them and if any of the patient's depression or anxiety is making their pain worse. A lot of times controlling these will help control the patient's underlying pain. We also want to ask about contraindications to opioids, acetaminophen, antidepressants, anticonvulsants, NSAIDs, and skeletal muscle relaxants, depending on which therapies the patient is appropriate for at that time. Thinking about how we take care of patients' pain or asking about their pain-specific history, we do want to ask about certain things. Now, there are some helpful mnemonics such as old carts, PQRST, Socrates, QSSA tape. I usually see OPQRST and old carts used most frequently. So if you see here, this is an example of using the old carts, OLDCARTS. And this helps us stay organized in how we're going to ask about a patient's pain. So first, you ask about onset. When did your pain start? Was it sudden or was it gradual onset? Then you ask about location. Where does it hurt? Does it radiate anywhere else? Duration. How long have you had this pain? Does it stay forever or does it come and go? Characteristics. Is it a stabbing pain, a throbbing pain? Is it pinpoint needles? Do you feel numbness? Asking questions like that help us determine what kind of pain the patient's having and may be useful in trying to decide whether or not a patient has neuropathic pain versus nociceptive pain. Aggravating factors. What makes it worse? Relieving factors. What makes your pain better? What treatments have you tried before? Have they worked? And then finally, the severity. Now, if you want to use PQRSTs, it's the same thing with onset, when did your pain start, and time being separated of how long that you've had this pain. Palliative and provoking factors are together, so this could also make you think palliative and so what makes your pain better and provoking what makes your pain worse, similar to the relief versus aggravating factors in old carts. The quality of the patient's pain kind of takes the place of characteristic. The region radiation takes over location. We are asking about where did the pain start and did it radiate anywhere else. And then finally, severity, asking from a scale of 1 to 10, how would you rate your pain? Some other things you can consider to get for a patient is objective information like laboratory values. In some cases, labs such as testing for rheumatoid arthritis can help us determine what the underlying cause of the patient's pain is. Getting vital signs. Sometimes vitals can be you can have hypertension and tachycardia when patients have acute pain. Getting a physical exam to determine whether or not the patient has any kind of abnormality is always important. And then you can also check urine drug screens to see if the patient has any positive UDSs. Now, there are some pain scales that you can use, and you can see that there are several of them. The numeric rating scale and the visual analog scale are two of the most common that you will see used in practice, and also you will see on rotations. You also have the critical care observation tool, which is used in critical care, and then the behavioral pain scale that will also look at behavior, and some that are used for things like dementia. But again, this is probably the two most common you will see. There are neuropathic pain scales as well. However, they're not used as frequently in practice, and I just want you guys to know that they exist, less than actually knowing all this information.